We have Dr. Michael Garber joining us today for the presentation on, I feel like, a very important but very overlooked subject, which is the health impacts, health policy, and parking. Michael he's an epidemiologist who got his PhD at Emory University, and in Atlanta, Georgia, and I cannot think of a better place than Atlanta, Georgia, than to study the health impacts of parking. And he is currently a postdoctorate researcher at UC San Diego. So let's welcome Dr. Michael Garber, everybody. I'll give it over to you, Michael.
Thank you so much, Bo. Okay, I think we should be good to go. Okay, so thank you again, Bo, and Paula and everyone for having me. It's a real honor to be presenting in front of this group, which kind of is spearheading, of course, parking reform, both in the United States and, as I'm realizing, globally as well. So yeah, my name is Michael Garber, as Bo said, and the title of my talk is Parking Space in Public Health. So as Bo gave a bit of background about me, but I'm an epidemiologist by training, and in previous work, I studied effects of bicycle infrastructure on biking and biking safety. And in my current role, I investigate health impacts of a range of urban planning strategies. And I have a particular interest in policies that address car dependency. And I'm here because, in collaboration with some colleagues, recently wrote a review paper trying to connect parking with public health. And we wrote this paper because although there is a long tradition going back to the early 2000s of investigating how the built environment affects public health, there was no review paper in the public health literature on parking specifically. And we thought this was an important gap to fill given the ubiquity of parking and also the current policy momentum as spearheaded by this group on parking reform. We're, of course, not the first to make the link between parking and public health. In 2020, a member of the Parking Reform Network wrote a post describing how parking is a public health issue. That was kind of at the onset of COVID, when public health was in the forefront of everyone's minds. Donald Shoup also, of course, saw the links between parking and public health decades ago, noting links between parking and automobile dominance, as he put it, and air pollution. Henry Garber, in his recent book, has essentially an entire chapter devoted to the environmental health consequences of parking. So our purpose with this paper was to, using these resources and other literature, try to connect public health, essentially position parking as a public health issue within the various strands of literature in transportation, urban planning, and public health. So my talk today has three main sections. First, I just want to kind of either remind many of you probably, and also describe to those who aren't familiar just the amount of land in the United States that's occupied by parking. And then I'll go through the pathways linking parking with public health as we talk about in our paper. And then finally, I'll go through how I think parking reform directly aligns with established public health theoretical frameworks. So first, just going through some estimates of how much land parking occupies. In 2010, Chester and colleagues sought to quantify the extent of parking in the United States, considering several scenarios, including off-street parking, on-street parking, and structured parking. And they came up with 5 scenarios, kind of ranging from lower amounts to higher amounts. And then recently in 2022, some of these same authors essentially narrowed it down to these scenarios 2, 3, and 4. So based on their expertise, it seems that they're suggesting about between 730 to 840 million parking spaces in the United States, which is almost as big as the land area of Massachusetts. Wow. And Henry Garber also, I think, reviewed the same literature, and in his recent book, recently also stated that most studies put the value at a little under 1 billion spaces. We came across another data source estimating parking's land share created by authors affiliated with the United States Geological Survey. They use satellite imagery data to estimate the extent of parking in every United States county. And summing their estimates from 2012 results in about 14,000 square miles of parking, so actually more than the estimates by Chester et al. And then finally, I was amazed by how accurate Donald Shoup's ballpark estimate was, or at least in relation to these other estimates, because he wrote about 4 parking spaces per car, which results in about, well, 13,000 square miles. So it's essentially between the two estimates, which I thought that was remarkable, and it also suggests to me that these are all kind of accurate to a rough approximation, although it's probably I don't think anyone knows the exact amount, but you can say about the area of Massachusetts. And there's also been some great studies that have gone over parking's land share in specific cities. So recently there was a study in San Francisco. There's a good study out of Phoenix and LA County. And then I know the Parking Reform Network also has a data set using OpenStreetMap data that quantifies this. But it seems like kind of in the mid-teens would be a high land share, and then maybe a little bit lower in places like San Francisco that are less car-oriented in terms of parking's land share. So with that kind of background context, I'll go through each pathway linking parking with public health that we've proposed in our paper. The first is by promoting driving in car-dependent environments. The second is by covering land with impervious surface. The third is by affecting housing affordability, and the fourth pertains to the design of parking, so particularly the design of on-street parking, and then also emissions from construction and maintenance of parking. So beginning with the car dependency pathway, there's evidence that parking promotes driving, including in areas of high population density. And then parking policy also contributes to car dependent environments, which has a range of public health consequences beyond driving itself. So there have been several studies that have assessed the impact of parking provision on driving. One noteworthy study, as I was reviewing the literature, is the study by McCahill and colleagues. I think this one's notable for its longitudinal design. So they followed multiple cities over time and estimated that increasing parking spaces per person from 0.1 to 0.5 led to a 30 percentage point increase in automobile mode share. And they make kind of in their discussion section, they go through several points, and it's their belief that they believe that the parking caused the driving, not the other way around. In another study by Weinberger, authors found that guaranteed access to parking at home was associated with more driving, controlling for some factors like access to transit and socioeconomic measures. And this one struck me because it's set in New York City, which is not somewhere that we usually think of as very car dependent, at least compared to other US cities. And then another study I wanted to point out is the study by Millard Ball, which they took advantage of a residential lottery and estimated that those that were assigned to homes with more residential parking had higher rates of car ownership and driving. So in addition to its direct impact on driving itself, it also creates or contributes to car-dependent environments. And I wanted to first define car dependency, so we're all kind of using common language. In 1999, Newman and Kenworthy defined car dependency this way, and I think, although it's 26 years ago, I think it still works quite well. They say car dependency or auto dependence is when a city or area assumes automobile use as the dominant imperative in its decisions on transportation, infrastructure, and land use. Other modes become peripheral, marginal, or essentially non-existent. And we can measure car dependency through land use patterns like low intersection density, low building density, and also by travel mode share. For example, there's a survey that shows that about 87% of US trips are taken by car, and even those that could be within walking distance, where they're a safe way to walk, I think it's roughly like 2/3. So it's still so high mode share is one way to measure, or high car mode share is one way to measure car dependency. Shoup, of course, made a persuasive case that parking minimums contribute to car dependency by effectively prohibiting density. He goes through a litany of examples showing how parking mandates require that parking lots are often several times the size of the corresponding buildings that they serve. And then when this requirement is propagated throughout cities, it results in low density. In chapter 5, he said that parking requirements do not necessarily cause this process, but by ensuring that parking remains free, they have exacerbated it. Henry Grabar in his recent book kind of made a similar statement. He said sprawl, which is essentially means car-dependent land use, has many causes, but parking is probably one of them. So on page 79, he says sprawl is built on a foundation of law and government subsidy that's quite complex, but within that labyrinth, parking is a powerful place to start. So in my opinion, just kind of reviewing this work, I would say parking policy is a cause of car-dependent environments insofar in that it's almost certainly had a non-zero causal effect on many of these measures. If we were to imagine a counterfactual history with different parking policy, the distribution of measures of car dependency would probably be different. So I would therefore define it as a cause. Of course, we can't know 100% sure because we can't go relive that past. But so in terms of the public health consequences of car dependency, there are two papers that I wanted to kind of highlight first that kind of served as a guide for the paper that we wrote. And the first is this paper by Miner and colleagues, which kind of exhaustively presents the various ways that car harm and what they call the system of automobility damages public health and the environment. And then there's another paper that's kind of similar, presents pathways between urban transportation systems and health. So just to go over the figure in the Miner paper, or figure 2 in the Miner paper, they go over these various externalities and how they're connected with public health and environmental health. So crashes, pollution, consumption of space, time, resources, etc. And then this is the figure in the Glasner paper, which repeats many of the same points, is organized a bit differently. And so I bring those up because I think it's important to recognize that all these are kind of intertwined, and organizing them in some ways is a bit arbitrary, but I think for the purposes of organizing pathways that result from parking policy specifically, I'm going to first discuss those that pertain to driving and car dependency, but are not necessarily related to impervious surfaces. And those include death and injury from traffic crashes, air pollution, greenhouse gas emissions, physical inactivity, and accessibility and mobility independence. But traffic crashes are a major global public health concern. They're the leading cause of death globally for people under the age of 30. I think in the US, it's always neck and neck between traffic fatalities and guns, unfortunately. In the United States, about 41,000 people die every year on roads. And I mean, the numbers are just are strikingly high, especially compared to some European countries. And compared to Norway and Sweden, for example, the per population rate is like 5 times as high in the United States. And it's particularly bad for pedestrians here in the United States. In 2022, we set a 40-year high for the number of pedestrians killed. And so car-centric environments caused them, parking is not entirely responsible for all of this, but environments that are kind of characterized by high amounts of parking are more dangerous for people both in and outside of cars. Air pollution is another major global public health concern that the system of car dependency contributes to. There were 22,000 estimated deaths attributable to traffic-related air pollution in 2015. A third consequence is greenhouse gas emissions. The United States, the transport sector is the largest source of greenhouse gas emissions, and cars and trucks, private motor vehicles contribute over half of that share. So greenhouse gases don't directly harm health, but they, of course, collect in the environment and cause climate change, which does have a range of health consequences globally, including heat, extreme weather events like wildfires and floods, climate-sensitive infectious diseases. They can cause it causes food insecurity and population displacement. The fourth consequence is car dependency's impact on physical activity. So compared with European countries, again, kind of compared with Europe, the United States has both high rates of traffic fatality and low rates of getting around essentially any other way besides the automobile. And car-dependent environments have been noted as a major barrier for people not walking. There's a survey paper done by some CDC folks that cited traffic as a major barrier for not walking. So simply, people just don't have access to safe and appealing places to walk. Walking and physical activity in general has a range of health benefits. So, if more people were walking, that would result in a considerable share of prevented premature mortality. There's a recent study estimated that even engaging in an additional 10 minutes per day could result in the prevention of 110,000 premature deaths in the United States. And then the fifth topic pertaining to car dependency is accessibility. So, for those with access to a car and the ability to drive it, abundant parking can confer accessibility to work, to school, to hospitals. But it's I think important to realize, and Anna Zivart's recent book points this out, that for about a third of the U.S. population, driving is not an option, either because they're children. Children also have a right to, or should have a right to be able to get around freely. Older adults, they've been involved with the criminal legal system. They're undocumented immigrants. They have a disability that may prevent them from driving, or simply because of the financial burden of car ownership and maintenance. So yes, parking can confer accessibility, but that access is unequally distributed. Garber put it, I thought, nicely in his conclusion. He says that parking represents access of the most superficial sort, one that often papers over deeper inequities. So again, parking is not the sole cause of these outcomes, but it is one part of the complex system of car dependency. And so by reinforcing this system, it contributes a certain share. The next pathway that I'll go over is impervious surfaces. So impervious surfaces affect public health in at least 4 ways. And by impervious surface, I mean like pavement, concrete, essentially what a parking lot is. So they increase urban heat, they decrease green space, exacerbate flooding, and contribute to water pollution. As you may be familiar, there's this phenomenon called the urban heat island effect, whereby parts of cities that have more pavement, more buildings, tend to be hotter than their surrounding areas that have less impervious surfaces. And urban heat, so intensified heat is becoming a more pressing public health concern as we enter this period of more climate change. It can cause heat stroke, heart attack, kidney problems. It's estimated that almost, 500,000 deaths per year globally are attributable to heat, and vulnerability, like many things, is not equally distributed. So older adults are particularly at risk. People experiencing homelessness are particularly at risk. I'm not aware of studies that have estimated the contribution of parking specifically to the urban heat island effect, but just considering how much parking, or how much land parking occupies with impervious surface, I think it's fair to say that it contributes a fair share. I think this paper by Honey kind of underscores the importance of this issue, especially in cities like Phoenix and LA, that many Sunbelt cities which have a co-occurrence of high amounts of parking and hot climates. They say in growing, sprawling, and hot cities like Phoenix, increasingly severe heat and pollution are 2 major threats to human health that are directly tied to automobile dependence. So the second pathway parking affects health through impervious surfaces, or lack thereof, is green space. So most fundamentally, parking affects green space by occupying land that could otherwise be a park. But it also affects green space at the regional scale, because it causes development to kind of sprawl into peri-urban areas, which decreases the amount of land that's dedicated to wilderness areas, for example. And there's an increasing body of literature documenting green spaces' effects on health, both in terms of short-term health and long-term health. For example, it can, exposure to nature or green space can reduce stress, provide opportunities for physical activity and socialization. And there's even evidence that, following people over a long period of time, that it can reduce incidence of cardiovascular mortality and even all-cause mortality. So I think this literature is still evolving, but there's some evidence that it does, that exposure to green space itself can benefit health. The third consequence is flooding, which is, as exemplified by Hurricane Harvey in Houston a few years ago. And Houston, of course, is a major metro area that is has kind of sprawling, notoriously sprawling. Researchers estimated that Harris County lost 30% of its wetland from 1992 to 2010, and that this likely contributed to the severe flooding event. Of course, not all wetland loss was because of parking, but parking is almost certainly responsible for its fair share. According to the U.S. Geological Survey data that I mentioned earlier, Harris County's parking land share is about 6%, which is the highest in the state according to this data. And in central Houston, this figure is probably much higher. The data from Parking Reform Network using OpenStreetMap suggests it's about 20%. And flooding has a range of health consequences, as exemplified by Hurricane Harvey. Displacement from homes, drowning itself, mental health concerns, spreading of infectious disease. And even if impervious surfaces doesn't result in flooding per se, it can cause excess runoff, which can kind of pollute, drinking water sources with lead and other materials that could be harmful for health. So that concludes that particular section. And the third pathway through which parking probably affects public health is through housing. The impact of parking on housing supply is covered at length by both Shoup and Garber. Grabar's book in particular essentially that's the main topic of the book so I don't want to go through that in too much detail here. I think they persuasively make the case. Just a couple studies of note. Manville conducted a study in Los Angeles in 2013 that suggested that after parking minimums were removed, there was more housing development in downtown Los Angeles. More recently, there was a recent law change in California that allowed that accessory dwelling units can be converted, or garages can be converted to accessory dwelling units. And some researchers studied the effect of this law change on housing and found that it did indeed increase housing supply. And then housing is kind of a long-standing social determinant of health. It can have a range of public health impacts. At the extreme, cities with higher housing costs tend to have more homelessness, and of course, people experiencing homelessness have increased risk of many health concerns, including higher premature mortality. Beyond homelessness, individuals might compromise on housing in ways that can affect their health. They may that the house might have indoor air quality that's not up to standards, or neighborhood characteristics that are undesirable because individuals may not be able to afford a home in a neighborhood that would have more health promoting neighborhoods. And then also just if someone spends more on housing, they have less to spend on other things that could be important for health, including healthcare, out-of-pocket expenses, fresh food, maybe a gym membership, just generally things that are necessary for health and well-being. So the final pathway is through parking's design, construction, and maintenance. So many of the pathways I've presented so far have generally been kind of in reference to off-street parking, but the first three topics listed here are focused more on on-street parking. So one issue with on-street parking is its effect on visibility. So it can be difficult for drivers and other roadway users to see around intersections if cars and trucks are parked right at the corner. And this poor visibility, if you can't see it, it could of course result in a crash. And this issue has gotten worse as cars and trucks in the United States have just grown in size, like an issue that David Zipper refers to as car bloat. So to address this issue, NACDA, or the National Association of City Transportation Officials, recommends a practice called daylighting, where parking is removed within 25 feet of the intersection, and ideally that space is used to narrow the intersection to reduce the crossing distance for pedestrians or people using wheelchairs. Another concern with on-street parking is that if a conventional bike lane is placed right next to on-street parking, it often puts the bicyclist in the door zone. And there's been a study estimated that dooring accounts for between 12 and 25% of of bike car crashes. This problem is also solvable. NACTO has suggested moving parking to the other side of the bike lane to make a parking protected bike lane. And just making sure that there's enough space between the bike lane and the parking lane so that the biker doesn't get hit by a car door. And on the other hand, on-street parking can have a potential benefit in that it can serve as a traffic calming measure. Traffic calming measures are physical measures intended to reduce vehicle speeds. On-street parking can effectively narrow the roadway, which can cause drivers to slow down, and speed is a major determinant of crash incidents and severity. So anything that that slows cars down is can be seen as a good thing. At the same time, there are other ways to narrow roadways that don't necessarily rely on street parking, including curb extensions, as diagrammed here by NACTO, and these things called chicanes, which kind of force drivers to pay more attention and slow down. So moving away from on-street parking, another way that design of parking can affect health is via so-called green parking techniques. So vegetation and trees can be added to parking lots to mitigate some of the negative consequences of impervious surfaces. So these techniques can address some of the parking health consequences like flooding or mitigate the urban heat island effect. Assuming the parking is roughly the same size, it doesn't necessarily address other fundamental issues like promoting car dependency or its effect on the housing supply. Finally, Chester and colleagues in the same 2010 study estimated how parking infrastructure contributes to greenhouse gas emissions. And they found that the production and maintenance of parking infrastructure contributes, at the high end, 150 billion, although probably the more realistic estimate is 67 teragrams of CO2 equivalent, which corresponds to, in terms of 2020 US emissions of greenhouse gas emissions, 1.5%. So non-negligible amount. So that concludes the section kind of covering pathways between parking and public health. In this final section, I'm just going to go over some public health theoretical frameworks that I think that show that parking reform kind of directly aligns with public health. The first is this public health pyramid, which was, or I should say, the public health pyramid, which was conceived of by Tom Frieden, who was a former director of CDC. In this paper, he asserts that interventions at the lower levels of the pyramid, such as socioeconomic factors or changing the environmental context to make healthy decisions the easier or default decisions. These types of interventions tend to be more effective in improving population health because they don't rely on individual effort and they're just kind of the natural state of society. So examples in these bottom few tiers would be adding iodine to salt, making sure people have clean air to breathe, eliminating lead and asbestos from homes. And I think parking would also be at the bottom of this pyramid because it's not something individuals really have control over, the distribution of parking in their neighborhood, I guess, unless they're advocates. But it's sort of a background factor that has many implications for public health. Keyes and Galea make a similar argument in their book titled Population Health Science. So they argue that public health really should be focused on shifting entire distributions of population health, kind of shifting the curve, if you remember from COVID times. And they note that acting to improve the entire population distribution does not necessarily mean that every individual within the population will be better off. So, in the case of changing parking policy, for example, there certainly could be people for whom, the status quo of parking abundance is beneficial. Maybe they have, they have the means to drive and they go to the gym for their physical activity. They don't necessarily rely on active transportation. So kind of the point with this is that public health should focus on shifting the whole distribution and not necessarily particular individuals within the distribution. Within their framework, parking would be considered what they call a macro social factor. And these are factors and systems above the level of the individual that shape the distribution of population health. Examples like political structures, the distribution of wealth, or importantly for parking, the characteristics of the physical and social environment. And parking. So I think parking essentially just really aligns really well with this framework because it's ubiquitous, as we've gone over, and it is a characteristic of the physical environment. And Keyes and Galea assert that small changes to these ubiquitous factors can have a major impact on population health. And then finally, a way of thinking about public health that I've been interested in lately is a framework called planetary health. And the definition of planetary health as posited by these authors in the Lancet is the achievement of the highest attainable standard of health, well-being, and equity worldwide through judicious attention to the human systems, be they political, economic, or social, that shape the future of humanity and the Earth's natural systems that define the safe environmental limits within which humanity can flourish. So it's a bit of a mouthful, but fundamentally or kind of practically, what I view planetary health as is seeking solutions that affect both population health and improve our ability to mitigate and adapt to climate change. Unfortunately, there are a range of solutions or a range of interventions that do address both, and parking is one of those, I would argue. As we've gone over it, it has many population health implications, and parking policy also has climate implications. By reducing car trips, it could reduce greenhouse gas emissions. Replacing parking lots with green space could sequester carbon, and it can help adapt to flooding. So to summarize, parking is ubiquitous, probably taking up about as much land as the state of Massachusetts. Parking likely influences population health through multiple pathways. I want to emphasize that more research would help to elucidate the influence of all these pathways. This is kind of like an organizational framework. There's research that supports all these pathways, but there's no study to my knowledge that goes all the way from parking to mortality. So it would be nice to have more research that kind of clarifies the whole causal chain. And then parking reform aligns with established public health frameworks, including the public health pyramid by Dr. Frieden, the macro social determinants of health by Keyes and Galea, and this notion of planetary health, which encourages the seeking of interventions that benefit both public health and the climate at the same time. With that, thank you for your attention. And I also want to acknowledge my co-authors, and I'm happy to discuss anything I presented. Thanks so much.